Kamper as the examinee, and Dr. Bailey will be the examiner.
Good afternoon, everyone. Thanks again to everyone for joining. And if you were here last week, welcome back. I was able to find someone to help out with the fact finding on the condition that I was the one on the hot seat, which is only fair. So my colleague, Dr. Bailey, who works with me here at the Tampa VA, will be the examiner. I don't know what she has in store for me, but I hope it's kind. All right. So I've, as we talked about last week, you'll get a couple minutes at the beginning to kind of write your outline and everything. I've done that. I'm using the Model for Fact Finding 2 handout, which is actually something that Dr. Bailey had developed. And I've written my, you can see, but my headings of my report. I'm ready to kind of go if everyone else is.
Okay, so you have written your outline already?
I have.
Okay. All right.
May I have an adult, please?
Yes.
Please don't give me a child, please. Okay.
All right, so this is a 65-year-old left-handed white male patient.
All right. Where was this gentleman referred from?
He was referred by his psychiatrist.
All right, and what was the referral question?
For a second opinion and diagnostic clarity.
Was there any records or any other details that came along with the referral from the psychiatrist?
He was previously diagnosed with an MCI by another provider. The psychiatrist disagrees and referred him for this evaluation.
But no additional records or anything?
Not about the referral question, no.
Okay. Want to just quickly jump back to some demographics. So a 65-year-old left-handed white male. What primary language spoken?
English.
Okay. Any other languages spoken in the home?
Nope.
Okay. All right. So what are this patient's cognitive complaints?
He feels foggy, endures poor short-term memory, some instances of kind of being inattentive, word finding difficulties, or how he put it, quote, saying the wrong word.
Okay.
Sometimes mispronouncing words.
Okay. And what is the course of these symptoms? When did they start?
Roughly 5 years ago, and with reported decline since that time.
Okay. Was there any precipitating event or thing that happened 5 years ago around the time that the symptoms began?
Yes.
Okay. May I have those records or details, please?
You can have those medical records. So 5 years ago, he experienced kind of a abrupt onset of suicidal and homicidal thoughts that accompanied kind of these cognitive symptoms. He was taken to a local hospital and was originally admitted to psychiatry floor, but was later transferred to a medical floor. He was admitted for 2 days with recommendation to follow up with outpatient psychiatry in his community.
All right. And was there any diagnostic testing performed during this hospitalization?
There was. I don't have that detail.
No, it's unfortunate. It's really unfortunate. Any medical procedures, surgeries, anything like that happened during this hospitalization?
I don't know.
Don't know. Okay.
I'm sure there are procedures, but I don't know what they are.
Okay. And since discharge, his symptoms have not improved. They have continued to decline. Is that correct?
Well, what symptoms are you talking about?
The cognitive symptoms.
The cognitive symptoms, he reports continued decline since that time.
Okay, thank you. How about the mood symptoms? Does he have a past history of depression or any other psych history? I guess let's just go there.
He has a history of anxiety and depression. No premorbid history of any SI or HI apart from that episode 5 years ago.
And was there any major psychosocial stressors around then? I'm thinking, death of a family member or loss of income or other major stressor in his life?
I don't know. Not that I.
Okay. Yeah. And since this hospitalization, has there been any recurrent SIHI?
No, that's the isolated episode.
Okay. How did he describe his current mood?
He said it's improved a bit since starting up with psychiatry.
Okay. Is he on? We'll get there. Any motor complaints?
Yes. He endorsed some right leg stiffness, difficulty lifting his right foot off the floor, some rigidity in his right arm. He also endorsed headaches that occur about 1 to 2 times a week. Occasional urinary incontinence, mild, that's happened for the past 10 to 15 years. He did say he sleeps fairly well, 6 to 7 hours per night.
Okay. Any history of or no noted nightmares or other sleep problems? No acting out dreams or anything like that?
Not that was reported.
Okay, thank you.
Why?
And what's that?
Why?
Well, I always just think it's a good idea. He's on the he's right around in the age range, but just to think about something like a Lewy body or some other REM behavior disorder. I'm not hearing a lot of evidence. We'll, get more details, but REM behavior disorders are relatively pathognomonic for eventual development of like an alpha-synucleinopathy, so something in the Parkinson's family, or the Parkinson's plus syndrome. So just wanted to kind of cover my bases there. Okay, thank you very much. Any collateral information?
Yes, he presented to the evaluation with his wife.
Okay.
Wife identified this similar memory and word finding difficulties. She's noticed that he has difficulty sometimes what seems understanding large amounts of information. His responses are not always congruent with the topic of the conversation. She noted that he sometimes talks in his sleep and has occasional kind of jerking movements in sleep.
Okay. Thank you very much. And we talked about the course of the cognitive symptoms. The motor symptoms, have those gotten better, worse, or stayed about the same since this hospitalization?
They've all, I'm sorry, did you ask about the course? They've all,
yes.
He feels maybe has gotten a little worse.
Okay. And did these motor symptoms?
That's been there for a while.
Right. Did the apparent lateralized right-sided stiffness and weakness, did that predate the hospitalization, or did that happen afterward, or as a result of?
It onset at around the same time, 5 years.
Okay. Yeah. Okay. Thank you very much. Any prior testing?
Yes, he was diagnosed with MCI by an outside provider outside of this, wherever he was seen. So,
okay.
But I don't
have
any
those records
on that, other than that's what they found or concluded.
Okay. what is his functional status as far as ADLs and IADLs?
He shares household responsibilities with his wife. His wife assists with managing medications. She feels like he gets kind of, or would get confused doing that, so she assists. He used to manage finances independently for the couple, but now daughter assists because family caught him making small errors.
Okay.
He passed a driving evaluation, but was recommended to have a passenger accompany him if driving to unfamiliar locations. He was employed, but was having some difficulties performing job duties in the past few years. So he stopped working about 6 months ago due to the cognitive symptoms as well as some anxiety.
Okay, thank you very much. Any family medical history that's relevant?
Nope.
Okay, thank you. Medical surgical history?
Prostate issues. I mentioned kind of the intermittent incontinence.
Mm-hmm.
He also has a long-standing, greater than 15-year history of intermittent dizziness, which has actually gotten a little bit better over time.
Okay. 10-year history, you said?
Greater than 15 years.
Okay. So a while.
Yeah.
All right. That's gotten better over time. Any other medical history?
No.
All right. And what medications is he on?
He is on a medication for his prostate, a vitamin supplement, and Trintellix for mood.
Trintellix. I'm familiar with that one. What is that?
I'm actually not sure. It's one of the newer ones.
Okay. That's cool. And any other surgical history that you can share?
No.
Okay. What's interesting to me, so I'll refrain from kind of doing the whole rundown now, but I was expecting that he'd have a history of hypertension or something like that, given some of the details that I've heard. When you're talking about this acute onset event, stroke or something like that came to mind. And it's interesting to hear that that is not in his medical history. His medical history is quite limited. So we'll be digging into that a bit more here in a minute. I just wanted to kind of share my thoughts there. What about social history, please?
So he is married. He's been married for 45 years. He lives with his wife and his adult daughter lives nearby. He used to enjoy golf, but he no longer plays.
Okay. Any particular reason why he no longer plays?
He cited the leg stiffness and the arm kind of rigidity in his right arm. And he said even though the Trintellix has helped with mood, he does still have some kind of lingering anxiety and depression that's really tied to his inability to do those things that he enjoys, like play golf.
Okay. All right. Any substance use history?
He drinks 1 beer per month and no history of abuse.
Well, there's your problem. Okay. All right. And any labs or relevant imaging that you can share?
No labs unremarkable. And there was imaging done about 3.5 years prior to this evaluation, but I don't have those results right now.
Okay, that's unfortunate, but fair enough. So I think I've covered everything as background. What did he do? I'm sorry, I forgot his educational and occupational history. Please provide those if you have them.
Sure. So he completed the 11th grade. He said he was a fair-ish reader. Didn't ever really like reading. He obtained a GED and had some college classes, he said, with average grades, although he didn't get any college degree.
Okay.
He worked as a quality engineer for the aerospace industry, and then worked for a government contracting firm for 14 years, again, before leaving about 6 months ago.
Okay. Was he having issues at work that were identified by coworkers or his boss?
I don't know. He just said.
Okay. Fair enough. Okay, so let me sum up what I know. We have a 65-year-old left-handed white male. English is his primary language and only language. He's got 11 formal years of education plus some college courses and a GED. It appears that he was in relatively good physical and cognitive health until about 5 years ago, had some sort of abrupt onset confusion that was accompanied by some SIHI that was out of character despite his history of mild, longstanding depression and anxiety. He was taken to an outside hospital, admitted for a couple days. Things may have been done, but we're not sure. Since that time, has had some declines in cognition, short-term memory, word finding, as well as ability to understand and process, it sounds like, larger volumes of information verbally. Motor symptoms have included, it sounds like, lower greater than upper right extremity stiffness and weakness, which has also gotten a little bit worse over time and has caused him to stop playing golf and doing some of the things he enjoys. Med history is relatively unremarkable, some prostate issues, some long-standing incontinence. Sounds like he's been talking a little bit in his sleep, but no overt REM behavior changes that would make me concerned for something in the Parkinson's family. So, okay, let me see here. And he drinks 1 beer per month. I'm really concerned about that. He did have to retire about 6 months ago as a result of all this, although it's unclear whether he was making any actual mistakes at work. I think that's all the background I have. Was any of that incorrect from what I asked for?
I think that was a good summary.
Okay, thank you very much. So, in thinking about what could be going on for initial differentials, there's a couple things going on. I was initially thinking it sounds like there's sort of a garden variety indolent neurodegenerative process of some sort that would be relatively idiopathic. But then hearing about this hospitalization and these lateralized motor symptoms, that's made me a little concerned that there may be some sort of acquired injury to his brain. A stroke would come to mind. He's in the right age category demographically, doesn't otherwise fit terribly well, and his medical history is silent for some of the things that I would expect in someone who would be at a high risk for stroke. But a stroke or any history of falls?
None that he reported.
Okay, so not hearing anything like that. It's possible he had a TBI or some other acquired brain injury, or sort of vascular malformation like an aneurysm that ruptured or something like that. So I'm going through my vitamins, and for those on the call who want to follow along, I'm using Dr. Bailey's differential table. So in vascular, I'm going to suspect maybe a stroke, like a ischemic stroke, large vessel. Lower extremity greater than upper extremity would favor ACA vessel, but I'll say ACA versus MCA stroke, or some sort of aneurysm or other, maybe a venous abnormality or something. It's a little odd if that were the case that it's continued to get worse over time. I would think with most acquired things like a stroke, it would have improved rather than gotten worse over time. So that makes me wonder if, there's no family history, but it could also be some weird genetic thing. I mean, moya comes to mind as kind of a less likely but possible sort of process that would be acute but also progressive. Going through my other differentials, I'm not hearing anything that would give too much concern for an infection, although it's possible. Traumatic, I'm not fully ruling out. I'm trying to write some things down here. There's no autoimmune history at 65. That would be pretty late for something to occur. I also don't know what would give you this sort of presentation with autoimmune. This doesn't really fit into autoimmune, but I was, initially thinking, could there be like an ALS or something with that right side? But it's been 5 years, and that is a terminal diagnosis that typically would be fatal with time point. So that is less likely. I'm ruling that out. Some sort of metabolic delirium. It sounds like the confusion is intermittent, but no evidence for that. As far as something neoplastic, it's possible there's maybe some sort of meningioma or very low grade malignant tumor. I would not expect anything like a GBM or something. The course has been far too long. No known seizure history. He's not on any anti-epileptic drugs. It's possible he may have had one in regards to whatever this is, but I'm not too concerned about that. Alcohol, substance use, I'm ruling out. Behavioral psych as a primary, I'm ruling out. It's very unlikely to be developmental at 65, so I'm ruling that out.
Did you ask for his developmental history?
What's that?
Did you ask for his developmental history?
Can I have his developmental history, please?
Unremarkable.
Thank you. Oh, gotta keep myself humble. Thank you. Okay. So, may I have some behavioral observations, please? I'm looking at the time and realizing I'm halfway through.
Yeah, I let you kind of talk through there because I didn't know if that was part of the exercise, but normally you would want to keep your summary brief. So, okay.
I tried to talk through my actual fact finding and I got interrupted and said, just put it your top couple. So, yeah.
So it sounds like your top couple would be something neurodegenerative versus acquired brain injury versus anything else?
Maybe some sort of cancer, like low grade something. Yeah.
Oh,
yeah, I think that's fair. Something vascular, either a large vessel stroke or a developmental abnormality, or an aneurysm or something. A idiopathic dementia with an oddball course or something neoplastic, I think would be my. And if it was a stroke or neoplastic, I would assume we're looking at a left frontal temporal sort of focus, given those motor symptoms he's having. But we will look at the data and take a peek and see.
Okay. So yes,
behavioral observations, please.
Yeah. So he was casually dressed, well groomed, and appeared a stated age. He was alert and fully oriented. He ambulated slowly with some kind of shuffling gait and what appeared to be kind of difficulty coordinating his right side. There was some right-sided upper extremity rigidity. Eye contact was within normal limits. There were some notable word-finding difficulties in conversation. Similarly, he had difficulty for kind of comprehension of long or complex information. And so task instructions had to be very simplified for him. Hearing and vision were fine. Behavior was appropriate. Those showed maybe some mildly reduced frustration tolerance at times on difficult tasks. Mood was reported as anxious, although affect appeared a little flat or blunted. Thought processes appeared linear and logical. He was an adequate historian and appeared to put forth good effort and build good rapport.
Wonderful, thank you. Something I had forgotten to say while talking through kind of my proposed neuroanatomy is a left sort of temporal-ish thing would also fit with these language symptoms he's describing. It sounds like there's more receptive versus expressive, although the fact that it's only for larger volumes of information makes me wonder if it's more of a disc executive thing, but we'll find out here. How would you best like to go through the data, given the exercise?
So I am going to share, well, I'll have to request to share my screen.
Oh.
I think I just approved it. Oh, yes, I just approved it.
Okay, thank you. All right, so let's see, I want to share. this screen. Here. Okay. All right. Can everyone see this blank sheet of paper?
Indeed. Indeed,
Okay.
All right.
I'm sorry. So, okay. So, yes, what data would you like? What would help
I
you
would like
determining what's going on with this guy?
validity first, please.
Oops, give me 1 second here.
Okay. Reliable digits is lower end of adequate. Forced choice is fine. No concerns for validity. Thank you. Premorbid, any premorbid testing or estimations?
I actually don't have premorbid. Where would you put him based on the information that I've given you?
Well, it's interesting. You know, his educational history was only 11th grade. And it sounds like he may have had some reading problems in school, but he was working as a quality control engineer. So I would probably put him solidly in the average range. Any general cognition or IQ testing?
I have a broad screen.
Okay. So this screening, and for those who don't know, the 3MS is sort of a super MMSC that has more subcortical stuff on it that we use here in Tampa. Those scores are borderline. Anything, or what did you lose points on?
I don't know.
Not sure? Okay. Any academic testing?
None. Nope.
Okay, good. How about sensory motor testing or neurologic testing?
Well, which one do you want?
Let's do sensory motor first. Okay, so looking at the groove pegboard here, wow. So again, he's left-hand dominant. That is wonderful. His non-dominant right hand, though, is very poor. There's a significant split there, a little bit less so for grip strength, but definitely still there. Strongly indicative of some sort of left frontally sort of thing, maybe frontal temporal, frontal parietal, but definitely some left hemisphere dysfunction there. How about neurologic or neurobehavioral testing? This table, okay. So I'm not seeing any evidence of basic visual issues. Some of those posterior frontal things that we're looking at with like the rapid alternating movements or the 3-step motor sequencing are okay. Repetitions were impaired. Is that for even basic repetitions?
I'm guessing it was as things became more complex.
Okay. No dyscalculia, no apraxia, perseverative ramparts, incorrect hand placement with the left hand, excuse me, that would not be right. Okay, so some
not lateralized. That's just
right. Yeah, thank you. So what I'm seeing from here, you know, it's actually a little more intact than I was thinking. I'm seeing some issues with repetition. Again, you know, one of my initial thoughts was something, maybe a receptive language issue. That's more of a posterior frontal thing. I would think if there was a major receptive language issue, there would also be some dyscalculia. I'm a little surprised that there isn't.
Where would that be? Dyscalculia.
So it's typically like an angular gyrus thing. I mean, you know, you can't completely reduce it to that, but the fact that there isn't any is a little surprising. Still could be a posterior frontal or temporal issue that's affecting receptive language for sure, but I'm also seeing some errors, perseverative errors, and organizational errors. Could speak to a right hemisphere issue since it was visual tasks. I'm suspecting it's still more of a left hemisphere issue, but I want to kind of see more data and test that hypothesis here. So thank you. How about attention? Okay, basic attention, maybe a touch lower than I would think, but broadly within normal limits. Were there any behavior observations related to digit span that you can share? Okay. Processing speed appears to be broadly within normal limits, which again is supporting something that's maybe a little bit more lateralized or localized, since processing speed is more of a diffuse function. Thank you. Additional processing speed measures, or is that all together?
Oh, what do you make of the fact that his digits forward is the lowest percentile?
Well, it's a good question. So a couple kind of competing hypotheses. On the one hand, it is the lowest, but it's essentially, you know, the same as at least backwards sequencing is a decent amount better. But that could just be incidental. It is an atypical pattern, though. I mean, you do see that in people with ADHD. That is not high in even on my differential. If there is a basic attention issue, you know, if there's fluctuations with attention, that could indicate that there's some sort of ongoing delirium or encephalopathic process. Otherwise, it's possible with a little test anxiety. He was noted to be a little anxious. So those are kind of my main hypotheses there.
Okay.
Can I see language, please?
Mm-hmm.
All right, and as I was, oh, that's interesting.
I don't know why I didn't
So,
the whole table, but is that okay?
Oh, is there more?
No, that like I meant the formatting like this.
Oh, yeah, that's fine. So he was given NAB naming, which is an easier task than the Boston, but did extremely poor. Verbal fluency for letters was within normal limits. There's a major split here with animals. Did something happen on the fluency task behaviorally that would be?
I gave you all the behavioral observations I had.
Okay. If I'm remembering my math correctly, it's out of 50, and I'm a little surprised to see the expressive score is lower than the receptive score. Do you have any other details about kind of what happened or what you lost points on?
I don't, but I could potentially theorize it was that repetition.
Okay. So, you know, I was initially thinking it was maybe more of a receptive language problem. This is suggesting, if anything, it's more expressive, although the math is pretty easy, so it could be a little bit of both. Thank you. Visual spatial functioning. So visual spatial functioning, the clock we discussed already. No simultagnosia. BVMT copy was okay. All right, so no gross visual spatial issues. Again, I'm conceptualizing those errors on the clock as being more of a left hemisphere error monitoring sort of thing, but need to wait till the end to kind of be definitive. Thank you. Memory, please. It's going to be a big one. Okay.
Yeah.
Okay, so thank you. So looking at memory, give me just a second here. Wow. Okay, In general, memory is poor. It's below premorbid functioning for sure. Looking a little more closely, there definitely appears to be a visual verbal split, with verbal memory being worse than nonverbal or visual memory. And in zeroing in a little bit more, he appears to have a pretty flat, low and flat learning curve. He does hold on to what he learns for the most part, and is able to recognize a bit more, but is making a lot of intrusion and false positive errors. Logical memory, thinking about, does he benefit from context? The answer appears to be no, but I would suspect logical memory is actually poor because of getting overwhelmed with that volume of information. And the logical memory recognition is essentially, well, it's below, but essentially at chance. Visual memory and visual reproduction is better. It's still not great, but this memory pattern in general is showing, like I said, verbal is worse than visual. And in terms of functions, this seems to be less of a temporal function, a true amnestic memory pattern. It seems more to be a dysexecutive pattern. I'm seeing some evidence of attenuated learning. He's holding on to, it seems like, to what he learns, but more information is causing him to do worse because he's getting overwhelmed. And then on visual, it's better, but he still has a bit of a problem with recall and really benefits from recognition. So that this would suggest, again, that there's more of an anterior left greater than right process going on. Thank you. Executive functioning. And I'm anticipating. Oh, that's cruel. So I was expecting executive functioning to be quite poor, and it's not. It's these scores are within normal limits.
So knowing that, you want to maybe revisit his memory performance?
Yeah. Oh boy.
Or you can wait till the end if you want.
No, I'll discuss it now. It still looks more like a dysexecutive memory pattern. Executive functioning is complex. The formal testing we do really gets more at dorsolateral prefrontal functioning. That being said, it's really odd and atypical to see a dysexecutive memory pattern that is, with these sorts of executive functioning scores being within normal limits. I am suspecting then that this could be more of a language issue, and that's why his verbal memory was so poor. That would make more sense. Although it kind of appears nominally dysexecutive, it may be just a touch further back, still a little more anterior, but more of a language issue than an executive issue. But I'll sum that up all here in a minute. Mood is the last thing.
Mm-hmm.
Okay. Okay. So, and looking at all the testing data, and speaking to the functions, the cognitive functions that are impaired, we have a gentleman here of average premorbid ability. Validity was okay. The functions that are impaired include left hand motor functioning, some evidence of kind of reduced basic attention. There's definitely some language issues that I think is a primary finding. His verbal fluency was okay for brief single words based on letters, but when it's more of a category fluency or that naming, that's very poor. Visual spatial functioning was within normal limits. Verbal memory was significant visual. Frank executive function was within normal limits, at least for dorsolateral. So, and kind of thinking about what's driving the bus here, I definitely think the left-hand motor is a primary area of dysfunction. I think language is a primary area of dysfunction. I would suspect it's actually maybe a touch more of an expressive versus a receptive language problem. But because the naming is so poor, that would speak to something that could be like an anterior temporal issue, potentially, something in that basal temporal naming area. I don't think there's a primary memory issue. I think the memory scores are low because of the poor language. And while executive functioning as a concept is relatively intact, there is still some evidence of some frontal lobe dysfunction because of those motor findings. So overall, this seems to be more of a left hemisphere process. I think it's possible it's a touch by with some of those on the drawing tasks on the neurobehavioral exam, but really this is localizing to be kind of an anterior temporal, posterior frontal, inferior frontal sort of problem. Not seeing any frank evidence of like a Broca's aphasia or anything like that. So, in revisiting my differentials and keeping an eye on the time here, I definitely think the vascular things I mentioned are still on the table. I think if this was a stroke, it's a little bit of an atypical one for like a major vessel stroke. Still could get something like this with maybe an ACA or M1, I think, or M2 branch MCA stroke. I think some sort of aneurysm rupture or other that type of vascular event is more likely if there is a vascular process going on. That's probably the top of my differential. I think I'm going to rule out TBI. This does not look like a TBI. That was initially on my differential. I still think it's possible there's some sort of low-grade tumor, but that's lower down. Something that I didn't discuss before that I want to put on the differential is, I'd mentioned a possibility of like a dementia. I think these language scores are severe enough that this almost kind of looks like a PPA, like a semantic dementia, which is a bit more anterior of the PPAs. That would not explain the motor findings or the hospitalization, but I think it's possible there's a multifactorial process that he may have had, a small stroke or something that happened that he got hospitalized for, and then, has this kind of comorbid dementia. I do think, though, the vascular thing is the most likely. That's at the top of my differential. And seeing some left posterior frontal anterior temporal dysfunction. As far as recommendations go, I think this is someone, and it's unclear whether he's received the services, but I would definitely, it's been a couple of years, but he may benefit still from PT for that stiffness. I think a PM&R consult in general for possibly some medications that can help with some of that motor stiffness. I think that could help with his ambulation and independence as well. Possibly speech therapy for some of these speech issues, although if it ends up being more of a neurodegenerative process, that may be less helpful, but still for some compensatory strategies. I'm not seeing anything that would contraindicate driving. I think the recommendation that he drive with someone in the car is probably a good one. But there's nothing here that would make me overly concerned for his driving. If he hasn't seen neurology, I would also definitely want to send him to neurology for a consult and get some repeat neuroimaging to see just what is going on with that left frontal temporal area. And depending on the results of those studies, I'd probably want to see him back in 18 to 24 months probably to see if there's been any further declines.
Okay.
All right.
So now do I get to ask you questions?
Yes.
Well, you mentioned seeing neurology. He has actually been followed by neurology for about 15 years.
Oh. Okay.
For ongoing monitoring.
Okay. That's interesting. You know, something like MS comes to mind. The demographics would fit. The motor, the strong lateralization and lack of, you know, more diffuse processing speed issues would not be consistent with MS. I had mentioned ALS. Again, that is an exceptionally long course. It's possible, but I think given that neurology has been following him, some sort of vascular, I still go back to that. Maybe he had an aneurysm or something. Or, you know, something like moya moya, that is, he's having small strokes or something like that, but some sort of progressive vascular condition like that. Yeah, that's interesting. Any neurosurgeries?
No neurosurgeries. I do have imaging, but I'm not going to give it quite yet. I'm curious. You mentioned kind of anterior frontal as an area possibly responsible for the motor dysfunction that he's having. And I'm wondering if there are other areas that can cause things like rigidity, difficulty moving.
Certainly.
And what are those areas and where are they?
Certainly. So yeah, posterior frontal would be kind of the primary motor. That was initially what I was thinking with the language issues too. But, you know, basal ganglia, while not the primary motor area, help smooth out some of those rough motor functions. And if there was something happening with the basal ganglia, that would also explain some of the rigidity he's having. You can get motor problems because of cerebellar dysfunction or something more posterior. I would not think that would lead to that stiffness. So I would think, you know, possibly a subcortical basal ganglia, again, on the left hemisphere, if it wasn't a posterior frontal, you know, primary motor issue. You could also see that with, if there was a issue with the white matter tracts. So something like an internal capsule stroke or something going down, it definitely, rigidity and stiffness suggests it's an upper motor neuron rather than a lower motor neuron problem. Something like ALS would give you both. There are some rarer variants of ALS that would be only upper motor neuron, but the fact that it's so lateralized is a little odd. But it's possible that there was something.
So he doesn't have ALS.
Yeah, between the motor.
I'm gonna, just for time, I'm gonna cut you off on the ALS thing. But okay, so white matter tracts. You mentioned the basal ganglia. What do you make of the fact that he was hospitalized for, well, actually, you know what? Let me give you this neuroimaging first.
Okay.
So he did have an MRI. Like I said, it was about a year and a half after that hospitalization, which showed chronic microvascular ischemic changes in the left greater than right periventricular white matter. Developmental venous anomaly and cavernous malformation are seen within the left basal ganglia, extending to the posterior aspect of the left insular cortex and left thalamus, associated with extensive hemosiderin deposition. Dilation of lateral ventricles, left greater than right, and left temporal encephalomalacia. So I'm just going to ask you a couple quick questions about this neuroimaging. What is hemosiderin deposition?
So hemosiderin is an iron product. It's kind of like what you get with a bruise, but because the neurons are terminally differentiated, that iron product doesn't get gobbled back up and recycled. It ends up sort of being this stain, and it's pretty much pathognomonic of some sort of bleed. So he's had a hemorrhage at some point in the past. It can be permanent. It can dissipate after decades, but he's had a hemorrhage, a hemorrhagic. You could call it a stroke. Yeah.
And so the question I was going to ask is, what do you make of the fact that he came into the hospital for suicidal and homicidal ideation, assuming that this hemorrhage happened at that time, 5 years ago?
There are cases of people who get sort of acute onset psychiatric symptom exacerbation. You know, the rule of thumb with he's older-ish, but older-ish adults is, you know, for new onset psych symptoms, and this is relatively new onset, it's neurologic until proven otherwise. You know, I'm trying to think of the exact way that can localize, but I do know in cases of strokes, particularly subcortical strokes, you can sometimes get these sorts of mood exacerbations. If there was amygdala involvement, or some of those limbic structures, that may be the reason why. If it's a subcortical stroke, that would make some sense.
Or thalamus, potentially.
What's that?
The thalamus, potentially.
Oh, yeah. Yeah. That would make some sense. Yeah.
Okay. Let me see. I think, what is a cavernous malformation?
So a cavernous malformation is a type of developmental abnormality. And I teach this, I should know, trying to differentiate that from a AVM. I think a cavernous malformation is when you get lots of tiny, kind of poorly formed blood vessels. And I believe there is not normal brain in between. It's almost like a tumor of these crappy little capillaries and blood vessels that are very prone to leaking and causing little hemorrhagic strokes, essentially. They tend to be neurodevelopmental and sometimes are silent, but oh my gosh. That is a very, very, very large one. This is a T2 MRI axial slice. That is a massive left cavernous malformation. Wow. Yeah.
All right. Very good.
Okay. We all done?
I think so. There were some comments that I completely, that was just people talking about where they're from. Yeah. Any questions about this process? Like I mentioned, I did let Joel kind of talk about stuff that if for the purpose of the exercise to see how you should talk through things, but I would probably suggest to make it a little bit more focused on what's in front of you and let them bring up random other things. So like when you kind of went on the ALS thing, I'm like, that's not relevant. So, you want to balance between showing your knowledge, but also managing your time in terms of not going through like all of the vitamins, all your differentials, everything that's possible. But I think for the purpose of this exercise, that's kind of why you did it, Joel.
Yeah.
I thought you did a really good job of not pigeonholing yourself into one etiology, but instead talking about the brain area. Okay, this is kind of left, whatever, right, whatever, subcortical, it's cortical, it's kind of lateralizing, or it seems more diffuse. All of that is good because you can tie it back to the data and really kind of solidify, okay, this is what's going on in the brain. Now let me think about what pathology is going to cause those brain changes in those areas. So I think you did a really good job of not sticking to an etiology up front. Like a stroke or whatever, this could have easily been a slow growing tumor. It could have easily been something else. And so getting, the nail on the head of a cavernous malformation, is not really the purpose, but kind of localizing it to those areas and really understanding, okay, what are the cognitive impairments associated with that neuroanatomy is really the point. And then being able to talk about the case once you get more information like the neuroimaging or whatever. So the fact that he'd been followed by, I guess, neurology for a long time, just monitoring that cavernous malformation. So
we talked about this last week, the importance of being fluent with the neuroanatomy. And I think, in my opinion, that's one of the keys of not getting stuck in a differential of like, the differentials are there, but if your thinking is always about the neuroanatomy, you can kind of jump to the differentials when you need, but you're not going to get as stuck. Any questions or
knowing the
diagnosis?
Would you revise your recommendations? That's a good question.
Well, I don't have to recommend seeing neurology anymore. I think, I would still recommend. So my recommendation for PT and some of those things was predicated on there having been something that happened that we think of as kind of an acute process. This course was a little atypical. You would definitely want to recommend like PT or OT if there was like a regular, large vessel stroke. I still think though, in this case, if he's having some stiffness, neurology should be managing that, but PM&R folks may be helpful in assisting with, that or accommodations at home. So I think the PM&R consult especially is still a good one. And coming back, this is someone I think we'd probably want to track in perpetuity, because this cavernous malformation seems to be bleeding at points. So
one question I didn't ask you was, why do you think he's reporting decline? In this case, really it's normal aging. I mean, he's hitting 65 and he's starting to experience some changes associated with normal aging, in addition to maybe some anxiety and depression. But there wasn't necessarily anything that was ongoing progressive. I think your consideration of something like moyamoya, I think, was a good one, or potentially some other type of neurodegenerative disease, but then also balancing that with the fact that he didn't really have any cerebrovascular risk factors. But yeah. I just wanted to point out that in a real fact finding, that probably would have been something that someone would have asked, like, why do you think he's declining, and talking about, well, normal aging, talking about the mood, all on top of that, I think can cause the report of decline.
Yeah, the motor declines threw me a little bit. I'm seeing a comment here in the chat from Sarah about MCI to major. So Sarah, a mistake I made, and I'd love to say this, I did this on purpose in order to, as an example, but I completely just forgot about it, was giving an actual cognitive diagnosis. I forgot to do that, and I should have done that before the recommendations. This would be a major neurocognitive disorder because of the IADL impairments. He's no longer able to manage his medications or finances, and that could be, out of caution. But for the purpose of a fact finding and not having the patient in front of you, you got to go with major. I think this is a major neurocognitive disorder. If this were my actual patient and I was able to suss some of that stuff out, there are times when you don't do a mild or major, you call it, it's stroke related or something. But this seems to be a progressive process, and the fact that it's bled before would make me more concerned that it's going to maybe happen again. And so I think a major neurocognitive disorder is the right diagnosis here. Nicolette, wonderful question. I will let my eminent examiner disagree if she does. I think, though, it definitely warrants its own diagnosis. And I didn't really talk about that in my Rex, which is another thing running out of time that I neglected to do. He's seeing psychiatry. That anxiety is still pretty pronounced. And it sounds like both the depression and anxiety are much worse than they used to be. That's likely related to this neurologic history. People that have strokes of any type are more likely to have these symptoms. So it does warrant, in my opinion, a separate diagnosis. Yes.
To me, it warrants a separate diagnosis because the mood symptoms, I believe, predated the injury, the hospitalization. If it was only secondary to that, then you may want to consider, like, maybe this is post-stroke depression and it has kind of that neurological underpinning. In his case, it's probably a little bit of both. It was probably pre-existing and then maybe exacerbated by the fact that he had ended up having a hemorrhagic rupture of that vascular malformation. But I would say I agree with Joel. It probably warrants its own standalone diagnosis. That's a good question.
There's a fun question about sleep there. You want to tell me, were those red herrings? The sleep talking and jerky movements, were those red herrings?
Yeah, the myoclonus in sleep.
We didn't, with a few more minutes, and I think, this is another area where I could improve for the real thing in retrospect. But you wonder about seizure history with those jerky movements. I could have asked more questions about that. I was focused on going through all the differentials and didn't. I do think, though, they're red herrings probably for this case. Yeah.
Yeah, it was a red herring. I think, it could be a little bit of sleep behavior disorder secondary to the fact that he had a stroke in his thalamus and basal ganglia. I don't know if that was there before. Now, this wasn't my case, so I have no idea. You know, in terms of like going through differentials early on, cortical basal degeneration can present with myoclonus and unilateral motor changes, but nothing else really fits with that. So, you know, I could see where someone would be like, oh, is there myoclonus during the day? And oh, it's just related to sleep. Okay, no. But yeah, it's a red herring.
The reason I didn't, and I could have said this, but that I didn't go down the seizure rabbit hole. You could, you know, I mean, you can have myoclonic nocturnal seizures. There was nothing that suggested there was something more going on, and he's not on any AEDs or anything. You know, Aaron could have said he's on, you know, pregabalin for mood when it's really for seizures or something like that. But there wasn't anything that made me think there was more. And the fact that he's being followed by neurology, I would be less worried about that. But you can get that with, you know, hemorrhagic strokes and cavernous malformations. You can definitely get seizures. Yeah. Other questions? We have a neurosurgical question. We didn't tackle that. No. So here's the problem, Amanda. I think, you know, and I'm obviously not a neurosurgeon, neither is my eminent colleague here. But, you know, sometimes cavernous malformations do get resected. You can kind of think of it kind of like a tumor. In his case, the fact that it's so large is probably why they haven't resected it, and they're just monitoring it. It would be very hard to remove without causing, you know, massive bleeding. There aren't any potential neurosurgical treatments I would think he would need. You know, if the bleed had been massive, they may have done something at the time. But there's nothing I would think that would be necessary now, or that could be realistically done. Nor if they resected the cavernous malformation, do I think it would really improve his cognition much. It didn't look like there was any mass effect on that image or anything that would be, you know, like a neurosurgical emergency. So you'd be removing the cavernous malformation just to remove it, but there's a lot of risks there. So I don't really think that would be helpful now. But that's a great question. Right, you're welcome. Other questions? Anything we didn't get to? I'm looking here. Okay. Well, thank you all very much for. Hope that was helpful to kind of see that in vivo, and I hope I did a acceptable job. Thank you. Hey, Sandra.
Thank you, Dr. Kamper and Dr. Bailey, for this. This is amazing.
You're very welcome. Glad we could demonstrate this on a Friday afternoon. So thank you all for having us too. Appreciate it.